This is scheduled as complications, but I'm really going to focus on one set of complications in adult deformity right now, which is proximal junctional failure. And I'll show you my thoughts on it, on why it happens, and some thoughts about how to potentially prevent it and reduce the incidence. So I do have some conflicts, none related directly to this topic. That's the list. So proximal junctional failure is a phrase that we came up with through ISSG, the International Spine Study Group, about 5 years ago now, and I'm delighted when I hear it repeated back. It's become kind of part of the vocabulary, and I think it really is a unique complication that had been previously described, but hasn't been previously kind of well defined and separated from proximal junctional kyphosis. And so in this talk, I'm going to talk a little bit about what is the definition of proximal junctional failure, what are the risk factors among patients with adult spinal deformity, what are the mechanisms by which it occurs, and then a bit about how it can be prevented. So the definition of proximal junctional failure is related to a similar complication that's been described for years called proximal junctional kyphosis. But it is definitely distinct in my mind from proximal junctional kyphosis in the sense that it includes a mechanical disruption at the upper end of the construct. So yes, there's kyphosis, but in addition to the kyphosis, there's either a fracture of the anterior vertebral body or a posterior osteoligamentous failure, or both. And that's really the distinction between proximal junctional failure and proximal junctional kyphosis. Proximal junctional kyphosis is essentially a recurrent deformity or a new deformity of kyphosis without those features, and is typically a very benign phenomenon that is bothersome to us as surgeons looking at x-rays, but really seems to have very minimal clinical effect for our patients. So this type of problem, the proximal junctional failure, has been referred to by other surgeons in prior papers. The original description, I think, was from John Kostwick, and he called it topping off syndrome, which is very much the same phenomenon. A couple of papers out of Washington University in St. Louis used the failure proximal junctional fracture, which I don't like because in some cases there isn't a fracture. I'll show you a case of my own where there really is not a fracture. It's a mechanical disruption, ligamentous entirely, without bony fracture. Fracture above all pedicle screw construct is a phrase I think a bit cumbersome. And then I had a phrase in a paper about 10 years ago about kyphoplasty at proximal junctional levels called proximal junctional acute collapse. I really think proximal junctional failure is a more concise description. So it's increasingly recognized. These are a number of articles that are out there. This now needs to be updated. There's at least 10 or 15 more articles that have been published in the last 6 or 7 years, as it is increasingly recognized and described by authors around the country. Here are some more recent articles, and there are still even another 5 or 6 since these articles were published. But I think what all of these show is that there's a significant incidence of at least 5 to as much as 40% depending on the patient population and the surgical group, with revision rates ranging up to 13 to 50% in some patient populations. So I think that's critical to recognize that this is something we're causing or seeing, and it obviously is often enough in these patients that we need to do something to get this rate down. This is one of my worst examples out of my practice, and really brought home the notion of what this phenomenon is and what the risks are. This is a woman that came in with a non-union and flat back. You can see on the far right her imaging, and none of those levels were fused. So we treated her with a front and back procedure. I didn't think this deformity, in my opinion, didn't require extension to upper thoracic spine. She did have osteopenia, and I didn't treat her at that time with Forteo. This was prior. My current protocol would be to prepare her for surgery with Forteo if we can get it approved for at least 6 months before intervening, and then keeping her on that for 6 months post-operatively. And it's also before I really was understanding some of the techniques you need to employ at the upper junction. So she went out with what I thought was a very nice correction, and she had a fall very early on in a nursing home, and actually successfully sued the nursing home for lack of assistance. She had called for assistance and finally had to get herself out of bed to go to the bathroom in the middle of the night and fell in the bathroom and suffered this dislocation. And you can see this really is not much of a fracture, but is a total disruption of the posterior ligamentous column and the disc space, and suffered a cord injury, and we extended her up. She came into clinic on a stretcher. We took her back to surgery that evening and extended her up, and she did recover nicely, but she still has the effects of the spasticity, and she's now about 7 years out from that complication. So what are the risk factors? We know a number of them. Age is one, and age is probably a proxy for bone density issues, but clearly older patients and those with bone density issues are going to be at greater mechanical risk. It's clear that the extent of the sagittal realignment is part of the issue here as well. So large preoperative sagittal malalignment is a risk factor, and then doing surgeries that result in large sagittal corrections. So use of a PSO, again, we don't do that typically unless we're really needing a lot of sagittal correction. The extent of the operative change and increase in the lumbar lordosis and better pairing of PI minus LL mismatch is clearly a risk factor. And it is also clear that when we extend the fusion to the sacrum, and I think this gets to some of the comments that were discussed about PJF above a fracture patient, let's say, or above an infection patient or a cancer patient. It can occur in those populations, but this is really the population that's at risk, in part because of the pathology, in part because of the age group of people involved, in part because of the procedures we're doing, and in this particular case, many of those requiring fusion to the sacrum and pelvis. So what are and these have been verified. That was out of a study that we conducted with the ISSG database. Those have now been verified in several other publications and presentations, and have been extended to include high body mass index, low bone density as talked about, and medical comorbidities. And then there's discussion of whether the proximal endpoint matters. Some authors think, and there is some data to suggest, that upper thoracic levels are less vulnerable than thoracolumbar junction levels, although we weren't able to show that with the data out of the ISSG. So what are the failure mechanisms? One of them is that there's a vertebral body collapse at usually the upper instrumented vertebrae or the upper instrumented vertebrae plus one. I'm going to use the acronyms of UIV or UIV+1. That's what I'm referring to in this talk. Hardware pullout is also often part of that, and that can be a loss of fixation either from screws or from hooks or other means of fixation of the proximal junction. And then the posterior column disruption is a third failure mechanism, and that can go along with hardware pullout. I think if you see screws pull out, you know you've got failure of the posterior column, as was talked about earlier. That is a harder piece to identify and define still in this pathology as for isolated trauma. So another step we took within the ISSG was to develop this proximal junctional failure severity score, and this was developed very much in analogy to the work that Alex Vaccaro and the spine trauma study group did with the TLIX classification. So, and I didn't weigh in at the time of Kojo's talk, but part of the benefit of that classification, in my opinion, is that it gets us away from classification systems that are really discrete boxes. And if you looked at the AO classification, it still retains this feature of you're either a type A or a type B or a type C. The problem with that is that we don't all see the entity in the same way. So some of us are going to see it as an A or a B, and there's a much lower agreement and observer and intra-observer reliability as a result of these classifications that have finite descriptions or finite numbers of boxes. With a scale, you get into a situation where we don't have to have perfect agreement. So I may run a classification on a patient and end up with a score of 8. Somebody else may end up with a score of 9, but we're in the ballpark, and that allows us to still have high agreement and high reliability. So scales, I think, are better approaches for classifications than discrete box-based classifications. So that's the reason, another part of the reason that we use this as the jumping off point. And you can see the we have 6 features that we think are important in assessing the severity, and those include neurological deficit, as you see, the total amount of pain. Is there a problem with instrumentation? Because if there is, a lot of times we're going to revise on that basis. And then the extent of the kyphosis, which is probably a proxy in this case for presence of proximal ligamentous complex failure, and then the severity of the fracture. And some situation, some of our members felt that including the level as at one point made a difference, that they were more likely to revise an upper thoracic level because they felt it was a worse actor neurologically potentially than thoracolumbar junction. But if you look at that, I think that classification highlights the importance of proximal junctional failure. So translation, which is part of the feature and results in a higher score, that can't happen without without failure of the posterior column. If we don't see hardware failure, the posterior column is more often intact. Again, lower amounts of kyphosis probably reflect an intact posterior column. We don't get neurologic deficit nearly as likely without a posterior column failure, and ultimately we don't revise as often. So what I took away from that classification as we developed it and have been thinking about it is really what results in a bad actor here is the same features maybe that result in bad actors for isolated trauma without fusion, which is the integrity or failure of the posterior column. And so here's an example of my own, and this was a woman that really taught me a lot, and I think is kind of an unfortunate outcome overall. So this is a woman who came to me with mainly lumbar stenosis, a relatively small curve, 1-level fusion that has kind of now collapsed above that and degenerated and become symptomatic. And this is not someone who's having significant sagittal imbalance. We're really just treating a problem of stenosis clinically. And I did what I thought was a successful fusion to T10, again without protection of the upper levels. She developed a very mild form of PJF, so a compression fracture of T10, but didn't really progress much in terms of the vulnerability neurologically or with respect to progression of deformity. She does have now what you'd call reciprocal change at the upper junction, but not much in the way of symptomatology. I think I'm getting her confused. I'm sorry. That actually was a very successful patient, and she was very happy. And again, it highlights the overlap maybe of PJF with PJK, which in this case really the deformity or the fracture really only resulted in deformity. And despite that being kind of painful to look at for us as surgeons, her clinical outcome has been great, and she really has never needed, now it's 7 years out, never needed anything done further above that. So what are the described preventative techniques that are out there? Vertebral augmentation is one. I wrote a paper about this now almost 10 years ago, and I'll go through why I've kind of gone away from vertebral augmentation in most cases nowadays. Proximal hooks are described by some authors and some surgeons. That's something I've used, but I haven't found to help in my own hands, and I think there's a little lacking data to really prove that it does reduce the incidence. Vertebral augmentation, there is data that it reduces the incidence. My concern with it is that it may aggravate or accelerate degeneration of the disc intervening between UIV and UIV+1. Moving the junction cranial from thoracolumbar junction to upper thoracic levels is described. I think if you have a situation where the deformity requires extension to the upper thoracic spine, then that's the time when you should go there. In my mind, doing that additional surgery, that amount of additional surgery going to T4 or T3 or T2 just to prevent notions of proximal junctional failure, I think it's a lot. So I'm not sure it's an effective preventive mechanism. Tuning the correction, I think, is something that we need to pay close attention to, and we're getting better at predicting what we need for sagittal realignment. I think we used to kind of go for a home run in older patients, and we're learning that maybe older patients may not need the exact pairing of PI and LL or exact full correction of SVA. They may like to be a bit forward. That may be part of it. And in addition, though, getting the lordosis right does seem to be a feature. And if you think about it, if you under lordose, you're going to create flat back, which mechanically creates the potential for failure above. If you overlord-dose, then you're creating a situation where the patient may want to be further forward and may voluntarily or volitionally feel that they need to move forward, and that may create some risk as well. And again, the data we had out of our ISSG data set suggested that it occurs in both of those settings. Laying in the rods to the upper screws is something I started doing probably 6 years ago, and I think is really critical, and that's really reduced the incidence in my own hands. And what I mean by that is if I'm fusing to T10, I'll get whatever lordosis correction I'm getting by about T12, and then I get out the bending irons, and in those upper sets of screws, I bend the rods down into T11 and T12, so there's zero pull-out force, at least as the lay on the table. And in prior days, I used to use a rod holder, and I just push it down into those upper screws. You're creating a mechanism for pull-out and a preload in that setting. So I think that's a critical element of technique. Limiting proximal dissection is also something we have to be very, very careful about, and particularly the ligament between, the interspinous ligament between UIV+1 and UIV, but also the facet joints immediately above UIV. And in the thoracic spine, that really takes some attention to avoid stripping that capsule, but that's, I think, also a critical element. But the truth is that many of these have very little data to support them. And I said I think vertebral augmentation has the best data of all of these to support them, but even that I think is relatively limited, and again I think has some downsides in and of itself. So this is the case I started to talk about and thought I was going to show previously. This is a woman that really taught me a lot about this phenomenon, unfortunately. And this is a woman, again, I'm treating her just for symptoms of spinal stenosis. She has a curve that doesn't cause structural problems or imbalance problems in and of itself. And so we did a T10 to the pelvis fusion. We got her nicely matched in terms of pelvic incidence and her overall lordosis. And we used, at that time, the cementation above the junction. She did very nicely, but between a year and 2 years, she became very symptomatic from this breakdown. And I think if you look at that disc, that really is very arthritic and in a relatively short time, despite what I think was a fairly appropriate alignment. So that makes me wonder, is that something we're doing besides just the fusion? And I think the cement, it's been shown that it may affect the nutritional access for the disc by osmosis through the end plates. It may rob the vascularity from the vertebral bodies and create a nutritional problem. But I think it also creates a mechanical problem that you now have hardened those two vertebrae. Now, maybe using less cement, I've had some surgeons look at this and say, well, I use less cement and I don't see that problem. Maybe, but again, I've gone away from that as a technique. In her case, we extended her up, so now, despite cementation, despite appropriate alignment, we'd worn out within a year, and extended her to T3, so now we're talking about upper junction, not lower junction, and I used TP hooks at the upper level about 2 years after her index operation, and she very quickly broke that down. This is a much faster failure, more typical of what we call proximal junctional failure. That last one I wouldn't call proximal junctional failure, but it was proximal junctional degeneration. Here, we're talking about failure with pull-out of the hooks and disruption of the posterior column, really profound kyphosis at thoracolumbar junction or cervical thoracic junction. So again, moving further up her spine in order to control this. And this, for a patient who started out with mainly spinal stenosis, this is not an acceptable outcome. And she's done reasonably well, and she accepts the overall level of function. But this is not the kind of outcome you want for your patients. And these patients, there's limited reports on how patients do with cervical thoraco-lumbo-sacral fusion, because there's relatively few of those patients, thankfully, out there. But if you really talk to these patients, if you find them, they're not functioning at the level you would like, right, despite our interventions. So all of that taught me, let's get back to the posterior column. So none of the techniques that I used in her augment the posterior column, and yet I think the posterior column may be the key to avoiding the disastrous complications here. So let's think about what are the techniques that are available to reduce posterior column failure. And there really are only two that I'm aware of. One is a spinous process augmentation, which I have gone to now and use routinely in every extended fusion, particularly in patients over 50, let's say. way. And rib fixation, which was a technique I developed about 3 or 3.5 years ago, maybe I want to say, and have used in a number of cases as well. And I'll review my experience with that. I'll tell you that since I adopted both of these techniques, I have not had a single patient, and now over 60 patients that I've had to revise if I've used one of these two techniques. So I've had some failures, meaning compression fractures, but I haven't had anyone that I've had to take back, thankfully, for revision surgery due to proximal junctional failure. And that's definitely a change from what I was experiencing before adopting these. So rib fixation, I initially did this with an off-label use of the Veptor device you see here. I ultimately used these soft sublaminar tapes as a tether, and then I have done also some patients with a two hook cradle, as you see in the lower right there, modified by cutting off the foot plate of one of the hooks. And it's a little hokey, but there's nothing out there besides the Veptor that's designed to attach to the rib as far as I'm aware, and the Veptor device costs $5,000 in my OR, just way too expensive. In fact, I'm surprised I was ever able to use it at all, but I've gone away from that as a technique more recently. So what we do, or why I think that's a good idea, I think it reduces the proximal dissection. I do this through separate incisions lateral to the main spine incision. It extends the moment arm lateral, so I think it makes a good mechanical sense. It allows other surgical techniques. You can do it with hooks if you like hooks at your upper level. You can do it with a spinous process tether. I've done that now in one patient with Ehlers-Danlos syndrome where I was really worried about soft tissue failure, so I did both rib fixation and spinous process fixation in her. It does create some significant OR fuss, maybe another 20 minutes of operating in order to accomplish this at the end of a long case. So this is what it looks like. I made a separate skin incision. You can see my finger on the upper incision on the right-sided photo there, and then we attach this down through a submuscular dissection or intermuscular dissection, blunt dissection down onto the rod and tighten that up. There's no devices that actually have a measuring gauge as far as I'm aware. I just feel the tape and by that measurement or that gestalt decide when I feel I'm tight enough that we've got tension established there. So our experience with that, I did a total of about 26 cases. I may have done a couple more, but I reviewed the first 26 that we did with this. There was a mean age of 68 years, so older patient group. I did 16 of them with metal, either the Veptor or the custom cradle I showed you, and 10 with a softer tether. The diagnoses preoperatively, we had 2 of these were rigid thoracic kyphoses. Those were ones that I did not take to the pelvis. 5 of them were patients I was treating for previous proximal junctional failure or kyphosis. 2 of them were patients with PISA syndrome or postural kyphosis due to Parkinson's disease. Again, a very high-risk patient population. 13 of them had DEXA scans preoperatively. I wasn't doing it routinely. Now I am. Of those, 7 of them had bone density issues, and 2 of them were frankly osteoporotic. And then, again, high-risk features in terms of their deformity. Their mean SVA starting out almost 10 centimeters, and the mean PI minus LL mismatch over 20 degrees. So our overall sagittal realignment, we got the SVAs down to a mean of 40 or a little less than that, and we got our mean pelvic incidence to lumbar lordosis mismatch down to about 11 degrees. 24 of the 26, again, fused to the sacropelvis, except for the 2 rigid thoracic kyphoses. We had some complications that were potentially relatable to the technique. One was a pneumonia. I wanted to see what were our pulmonary complications. One pneumonia, I think probably unrelated. One air leak from a woman who'd had a prior thoracotomy. That resolved without incidents, obviously related to the technique of stripping the rib. One patient with a pulmonary embolus that I think probably was unrelated, and that was postoperatively several weeks later, and is the only fatality in this series. The proximal junctional failure results we did still experience the phenomenon of proximal junctional failure. That should be 5 with proximal junctional kyphosis and 3 with proximal junctional failure, but nobody underwent a revision. So several compression fractures, none of which resulted in a need for further surgery. None of them really progressed severely. And this is an example of what I think is a very high-risk patient, a woman with a high BMI, multiple prior surgeries, osteopenia, and severe sagittal imbalance, and a 67-year-old female. And we did her with a posterior and then an anterior reconstruction, got the posterior realignment, and then came back as a second stage and took out those fractured vertebrae and completed her fusion. And she's done very, very nicely without any fracture above, and you can see the rib cradles there with the vector on the AP view, kind of what that looked like. Again, it doesn't look the same. You don't see the tapes because they're radiolucent, and she's now well past 2 years. I think she's about at a 4-year follow-up. I haven't seen her since her 2-year follow-up, but she'd been done very nicely through 2 years post-operatively. So in conclusion, proximal junctional failure remains a serious complication. I think we know a lot now about the risk profile. We know something about methods to reduce the frequency. I think there's no technique that's proven to eliminate this, but the ultimate solution is multi-pronged, both surgically technical approaches as well as planning, and I'll say preoperative optimization in terms of bone density I think is a critical element as well. But I think posterior column augmentation is really where we need to be looking, and I'll talk a bit more about the spinous process fixation technique. Didn't really have it in this talk, but that's what I've gone to now, and I really have liked that technique, and that was Chris Ames and Chris Shaffrey who really have developed that and taught me that.